GENERA Centers for Reproductive Medicine in Italy and laboratory director of the centers in Rome. Previously, she was laboratory director at the Center for Reproductive Medicine of European Hospital in Rome for 11 years. Her topic today is oocyte cryopreservation. What are the evidence? Dr. Laura, please.
Thank you very much, Mr. Chairman, dear audience. It's really a great pleasure to be part of this fantastic meeting. I really would like to thank the organizer for this opportunity. And this is my favorite topic, most of all. So, oocyte cryopreservation, what are the evidence? Do we have acceptable chance of pregnancy to offer this technology to our patient for any kind of reason, which can be age-related reason, but also medical reason and other reasons. So first of all, as an embryologist, I would like to underline that cryopreservation is really an essential part of assisted reproductive technology. And it offers a lot of opportunity. So I think that each laboratory has to have a very good cryopreservation program for any stage of development, because it is the only way to lower the number of embryos to be transferred while maintaining the same cumulative pregnancy rate. And of course, multiple pregnancy is something that we have to avoid in our treatment. But also we can delay the transfer of our embryos and allow fertility preservation. So cryopreservation is essential. It is estimated that it contributes to our take-home baby rate of about 30%, but with a systematic use of cryopreservation, I'm sure that this percentage can be much higher. And what about oocyte cryopreservation? It is a relatively new technology. It has been introduced only a few years ago in the routine, but it has already a key place, and we are here today to hear about this. It allows to preserve a female fertility, and it is very important when we think about medical reasons, but also social reasons, also for egg donation program, to avoid the production of supernumerary embryo where it is not allowed or where the patient has some ethical or moral or religious issue about embryo cryopreservation. You know that we had this problem in Italy for legal reasons, and also for the accumulation of excess oocytes in our eye cycle. So a very new technique with already so many applications. Every embryologist has to face this. We have to implement our lab with oocyte cryopreservation because we may face one of these or all these applications. So it is our responsibility. Why it has been so difficult to introduce oocyte cryopreservation? First of all, because it's difficult to obtain results, and we will go through this later on in the presentation, but also because for many years, and this is 2006 and 2008, there was a prejudice related to oocyte cryopreservation. It was considered as an experimental technology. And this is ISRM statement in 2006 and 2008. But today, things have changed. In 2012, I think this is a couple of months ago, the American Society for Reproductive Medicine has changed this label, and oocyte cryopreservation is not anymore an experimental technology. And why this happened? This is really important. Also to say to our patient, it is a very important statement coming from one of the biggest society in reproductive medicine, coming from America, but in this case we can trust Americans, I think. And this is based on evidence, on the literature, And I am so proud to be Italian, and you should be proud to be Spanish, because this evidence came from our country. For different reasons. In Spain, because of the egg donation program, and in Italy, because of very severe legal restriction. But this gave us the opportunity to set up a good oocyte cryopreservation program. So let's make one step back. Why it has been so difficult to introduce oocyte cryopreservation and so easy to introduce embryo. If you think that the first embryo was cryopreserved, was successfully done, I don't know, 40 years ago, and only now we are talking about oocyte. Just because the oocyte is a very sensitive and special cell, but has to do a lot of things. And at metaphase 2 stage, it's very sensitive to any additional treatment that we do in the lab. So it's really for the biological specificity of this cell that it has been so difficult to introduce cryopreservation, and also the dimension and the function of this cell, which is also very sensitive to aging and in vitro culture. So there was a reason why it has been so difficult. But now we have enough evidence to change our mind, and I would like you to change our mind. So this is some of the publication. There is a big bias here, because I have chosen all the publications coming from my center, but just because I know them better, and I can explain better what has been done from 2008 and 2012 to make the American Society change its mind about oocyte cryopreservation. And as you can see, we have randomized controlled trial, and this is very rare in reproductive medicine. Very rare to have randomized controlled trials, which has, of course, the higher level of evidence-based medicine comparing a new technology. ICSI was introduced without randomized controlled trial. Embryo cryopreservation was introduced without randomized controlled trial. But for oocyte, it has been done, and we should really look to these results. So, of course, the first evidence came from the lab. And this is Anna Kobo results, the first one that really introduced this Japanese technology inside her laboratory for egg donation program. And it came also from our center. We wanted to demonstrate how was the in vitro performance of oocyte after cryopreservation, in particular after vitrification. And this paper was published in 2011, was the most downloaded paper on human reproduction, and it was only dealing about laboratory evidence. So imagine how many people were interested all around the world about oocyte cryopreservation. So there's a great interest for many, many reasons. And what were our results? I was really surprised, and I was really happy that the in vitro performance of cryopreserved oocyte by vitrification was really similar to what we normally obtain with fresh oocytes. They behave in the same way. And this is sibling oocyte coming from the same cohort. We could do it because of our law that restricted the number of oocytes that we could inseminate at that time. Luckily, it changed. So you see no statistical difference for any of the parameters. And of course, a paper which is based on sibling oocyte, it's a very trustable results, although the number are not so high. But this is only laboratory results. As I said, randomized controlled trials means high level of evidence-based medicine. And if you think about meta-analysis of randomized controlled trial, then you are on the top of the pyramid. Higher level of evidence-based medicine. So we can state today that oocyte vitrification works better than slow freezing when you think about survival. It's a statement. And that oocyte vitrified perform as well as fresh oocyte when you think about, fertilization. Here the outcome was fertilization rate. But in vitro performance is not enough. What we want is baby, healthy baby. So to know that the oocyte behave very well in the lab is only a very small part of the story. But it is much more difficult to demonstrate the efficiency from a clinical point of view because, of course, then you have a lot of confounding factors related to the patient. much more difficult. So let's see what we have, but there I cannot make any statement as I did for the laboratory outcomes. So this is our paper. At that time, we were obliged to inseminate only 3 fresh oocytes, and all the rest of the oocytes by law were cryopreserved. And here you have the results on the top line of a fresh oocyte, and here the results obtained in the same patient, the patient that failed the fresh attempt. They come back to make a second attempt with vitrified oocytes. And what we notice is that the results are generally lower when you use vitrified oocyte, but it's not comparable. The best patients have been lost in the fresh attempt because they got pregnant with a fresh oocyte. So we cannot really compare the two. And here the transfer was done on a spontaneous cycle. Here it was a stimulated cycle, so the endometrium can be different in favor of vitrified oocyte in this case. So it's really confusing. So I don't want to compare the two groups. What I want to show you with these slides is that in young patient population, where we know that the oocytes are of very good quality, younger or equal at 34 years old, the result was 43.2 delivery rate. This is not a clinical pregnancy, this is a delivery rate, they're all born. So what you expect with vitrified oocyte from a very young woman is to have as high as 43, which is exactly the same as what we obtained in the GENERA population with fresh oocyte. And strangely, 1 year later, a few months later, we had the results from the randomized controlled trial performed by Anna Kobor and colleagues. This is a beautiful study, randomized controlled trial on fresh versus vitrified oocyte in an egg donation problem, very few confounding factors. And what they found, surprisingly, is that vitrified oocyte and fresh oocyte with young oocyte, with good quality oocyte, was around 43%, exactly what we saw in our patient population of infertile women, but with very young, less than 35 years old. So it came in my mind that age and oocyte quality is the real confounding factor, not vitrification itself. When you think about results, first of all, we have to think about what we are using. So we tried to go on with our study, and we made a multicentric longitudinal cohort study. We want to see the reproducibility of the technology in different centers for different indications, all in the infertile population. And this is to put the number together, to have more numbers and more convincing results. More than 2,000 oocyte, the survival rate when you have a normal routine application of oocyte vitrification of any kind of oocyte at metaphase 2 stage, it is expected to be around 85%. Although in the study it was higher when you introduce it in the lab and everybody is doing it as a routine, this is the reality. And it was consistent in the 3 centers which were expert in oocyte cryopreservation. So I would say that we should expect 85% survival rate. And what we obtained at the end of the story, 128 deliveries, 147 newborn, but also some embryo that were re-vitrified a second time. So I could express the results saying that we obtained 5.4% of the oocyte became a baby in this study. But what happened is that the best patient has still some cryopreserved embryo from this cohort because they got pregnant on the first cycle, while the worst patient has used all their oocyte to obtain, not to obtain the pregnancy or to obtain the pregnancy. So it's very difficult to make a percentage of oocytes because they are linked to each other. The cohort of oocytes, each oocyte from the same cohort are linked to each other. So what I like to do is to consider the cohort as one and not each oocyte as one, because like this, I have included the confounding factors coming from the patient. So we did a different kind of analysis. We did what is called a partitioning analysis. So the outcome was the delivery rate. So here you have that in GENERA population, we obtained 128 delivery, which means 28.4% of delivery in the GENERA population of infertile women from 30 to 42 years old using vitrified oocyte. So this is the general population. And then the computer says, okay, it is significant according to the number of oocytes. The most predictive value was the number of oocytes that was obtained by the patient. It's not for sure that we have used all these oocytes, but what is for sure is that if you have a good ovarian reserve, more than 8 oocytes, you have a double chance to obtain a pregnancy as compared to a woman that has a low ovarian reserve. Again, it's not that we have used all the oocytes. We have just categorized the patient good responder versus bad responders. And I'm not so sure that if you take 2 times 4 oocytes, this population of patients is the same as having 8 oocytes altogether when thinking about the quality of the oocyte. This is a no question. It's not the absolute number, but it is the number reflects, in my opinion, the quality of the oocyte that you obtain. But of course, we will know perhaps much later using higher numbers. Then the age has a very important weight. And in our study population, the cutoff was 38 years old. So if you have a bad response to ovarian reserve and you have higher than 38 years old, you have only 12.6% delivery rate. But on the opposite, if you have a very good ovarian reserve and you have a chance to have good quality embryo, this is something that you cannot predict before. So you go to blastocyst stage because you have enough good quality embryo on day 3, then the results, by having more than 8 oocytes and good quality embryos, blastocyst stage transfer is 62.1. Delivery rate is not 100%, but it is something I think really very, very interesting. But look, if you don't have good quality embryos, you cannot go to blastocyst. Even if you have a very good ovarian reserve, the results will be completely different. And this cannot be predicted when I think about social freezing or age-related freezing. You will never know how will be the quality of the embryo of that particular patient. So you don't know if, say, you need 8 oocyte, 20 oocyte, or 40 oocyte. Probably something that we will never know, as we don't know for fresh cycle. It is exactly the same problem. So last study that we have submitted just a few days ago, it's about what happened when the law changed. You know, but since 2009, we could inseminate only 3 eggs, and then we were vitrifying the rest of the eggs and looking to the cumulative results. Now we can inseminate all the oocytes. We don't have restriction anymore on the creation of embryo. So we inseminate all the oocytes like everybody does. We select the best embryo, we freeze the embryo, and we come back. And these are the results. So it is a fantastic model to see how oocyte cryopreservation works for a particular patient. So which is how we can predict the pregnancy when using all the oocyte that has been vitrified at oocyte stage or at embryonic stage. And surprisingly, we didn't find any difference. In the fresh cycle, a slight improvement, but not significant, and the vitrified cycles works as well when you use oocyte vitrified or embryo. So it seems that really the in vitro performance is the same, but what's the significant difference between the 2 groups, which is very important, is the number of cycles that the patient has to do to get the same results. If you go to embryo or to blastocyst, you will have less embryo, which means less cycle for the patient. When you do oocyte cryopreservation, and I think about also social freezing, if you freeze or you vitrify 20 oocytes, how many cycles this patient will have to do before saying there is nothing to do anymore or to get the pregnancy? So the difference is the absolute number of cycles that the patient had to do to obtain exactly the same cumulative results. So 258 when we use embryo cryopreserved, 297 when we use oocyte cryopreservation. There are 40 additional transfers that the patient had to do to obtain the same result. And I think it's very important, also related to the time to get the pregnancy. So according to this, I would say that if a patient has frozen or vitrified the oocyte, 20 oocytes, I would warm all of them together when she will be ready with a partner, create the embryos, and then eventually re-vitrify the embryos, because I don't want this patient to go through 5 or 10 attempts. I think it's not fair, but this is something also open for the discussion. So now, potential risk. IVF has potential risk, that's for sure. But it's not only related to oocyte cryopreservation. Any kind of assisted reproductive technology has some potential risk that are related to metabolomic, transcriptomic, proteomic, epigenetic, who knows? We know that this is there. This is there also because we are treating an infertile population which is at high risk to have these kind of problems. The population itself is at risk. But one thing we know is that the chromosomal abnormality is related to the age. And it's a dramatic correlation. And we know that, according to our results of PGS, at 40 years old, you have about 75% of the embryo that has chromosomal abnormality. So if I think about using 32 years old oocyte cryopreserved or fresh oocyte of a 41 years old, I would say that it's much more safer, for sure, to use young oocyte. Because although we have not enough data about oocyte cryopreservation, we have a lot of data about chromosomal abnormality, age-related. So it is, for me, a safer procedure, safer than the art in general. And it is also published in different studies and also to our experience in the baby born. So to conclude, I am a woman, I'm over 40, unfortunately, and I have to say, although I have 2 children, that there is a biological inequity between males and female. And we are only talking about female preservation of fertility, but what about the man? I'm sorry, he can freeze his sperm whenever he wants and have baby over 80 years old. I think we should restore an equity between male and female based, of course, on evidence-based medicine and on good counseling to the patient, saying the truth, that there is no guarantee of success in medicine in any treatment. And also with oocyte cryopreservation, even if you have a very good response and you freeze a lot of eggs. This is true also for fresh cycle. But what we also know, that oocyte cryopreservation is not an experimental technique. It is a very efficient technique at any stage of development. There is a lot of results. There are randomized controlled trials, meta-analysis of randomized controlled trial. I'm sorry, vitrification, it is an effective technology which is not experimental and can be used as we use embryo vitrification, blastocyst vitrification, and sperm cryopreservation. So coming back to the original question, can oocyte preservation really give an acceptable chance of pregnancy? I would say yes, as it is for assisted reproductive technology in general. Acceptable, age-related, factors-related, patient-related, sperm-related, and all the confounding factors that you can find in fresh cycle. So normally the last question is, if I can choose, should I freeze oocyte, PN stage, embryo, or blastocyst? First of all, you should vitrify, but that's another question. And secondly, I think that you can do it whenever you want. It's a philosophical problem. If it is for fertility preservation, why should you put a sperm from a donor when you can really efficiently cryopreserve oocyte? If it is for a couple, why don't you select the embryo as much as you can to have less embryos and less transfer to do to the patient, probably to obtain the same results? The total efficiency should be the same, because although you expect less implantation rate at oocyte stage because it's a less selected cell, but you also have an absolute number which is much higher, of course. You have 10 oocyte and 3 blastocysts. 3 blastocysts with high implantation potential, but 10 oocytes. So it is really in our hand, in our philosophy, according to the patient will, that we should choose the day of vitrification. Thank you very much for your attention.
Thank you very much for the nice presentation, Laura.
Thank you.
I would like to open this presentation for discussion. Yes, behind there is, please, microphone. Before he will start, I would like to ask, Is there any place now for the ovarian cortex to freeze instead of the oocytes?
Of course, oocyte cryopreservation cannot be used in prepubertal patients, so we have to find an alternative, and I know that there is very few centers that have already good results, especially I think about Scandinavian countries. I have no experience with cortex cryopreservation, so I cannot answer more than what I read from the literature, but I think that there will be very soon an available kit able to preserve also cortex.
But the number of the cycles that they have done the cortex ovarian preservation and transplantation is still unknown. You know?
It is still unknown in the general literature, but it is known from reference centers. I think about Anderson in particular. He has very nice results, consistent, but of course we are talking about very low numbers. But I'm not involved in this kind, but I'm sure that in the future it will be possible.
Okay.
There is good hope, I think, in the literature also for prepubertal patients and young girls that has to face oncological treatment, and we have to work also on this.
Okay. The question?
Michel.
Yeah, Michel Camus, Brussels. Thank you for your very clear presentation. What I would like to ask is, do you have data on implantation potential of vitrified blastocysts originating from vitrified oocytes? So 2 times vitrification.
I have very few personal data, but Peter Neggi in Atlanta, who is using, and also Anna Cobo, who is using cryopreserved oocyte for donating cycles. He made even 3 rounds of vitrification with similar results. So I think that blastocysts are really very resistant to vitrification, especially blastocysts. And I say this because of our PGD program, where sometimes we have to vitrify 2 times the blastocysts, and it's really working very, very well. Big data I cannot give, but single experience from Anna Cobo and Peter Neggi, they really show the same implantation potential when you vitrify blastocysts, even originating from cryopreserved oocyte or cryopreserved oocyte and vitrified embryos. So it's really encouraging. There was a poster of Peter of 2-round vitrification with the same implantation rate.
Can I complete also? We do mainly the zygote vitrification, and we do also the revitrification of the blastocysts, and we replace them later, and we have also good results with the implantation rate and pregnancy rate. And from Brazil, we have done 2 cycles also, and these are case reports published. So revitrification is possible, and it works, not like the slow freezing.
And what is very interesting with vitrification, that it can be done on PGDs, on embryo that has been manipulated for biopsy without any problem. And this was true for oocyte with the opening in the zona, but also for embryos and blastocysts. So this is a big difference with slow freezing, where we had a lot of problem for biopsied embryos. So I think it's really a great opportunity for the lab, and a great possibility to really cryopreserve whatever you have in any moment, according to the patient problem and the patient will.
Dominic?
I also have a question. You just said that you probably would prefer to thaw all the eggs at once, create possibly multiple embryos, and then refreeze them if you have too many, instead of having several thawing cycles. You just said that there's not that much evidence or experience with revitrification of embryos, so I wonder why would you then suggest it?
Okay, I suggested it's only thinking about the number of cycles that when the patient will come back. I'm thinking about social freezing.
Yes.
So today we are freezing, as you said, 10, 20 oocytes per patient, and they will come back in 2, 3, 4 years' time. I don't know, but probably it will take time before they come back, and I think that we will have evidence at that time. Anyway, to go through 5, 6 transfer, I mean, it is really a long story.
Yeah, but I think that the number of transfers will be the same, isn't it? Because you create, for instance, 5 embryos. If you thaw them all together, you put 2 back, and then you have 3 embryos, which you still have to transfer over multiple cycles.
No, but if you warm the oocyte 3 by 3, like we used to do because of the law, you will have, I don't know,
Oh, yes, in Italy,
six,
yes,
yeah,
yes.
six, no,
3 by 3
if you
is
just
yeah.
warm the number of oocytes, but you want to have only 1 or 2 embryos, it will be a very low number, so you will go through a lot of warmings. But if you warm all together, I'm just talking, I mean, in a, like this empirical way, and you keep them to blastocysts, you probably will have at the end of the story 3 or 4 or 5 blastocysts, which means that you transfer one by one, highly selected, and that probably that patient will have not more than 3 or 4 transfer, which is already a lot. And cumulatively, according to our results with very low number of oocyte used per time, cumulatively you will not lose anything. But the time to pregnancy will be lower.
And then one more.
Okay, if second round vitrification will not affect embryos, but has to be proven yet.
And one more question. Patients often ask whether or not the oocytes they have frozen are of good quality. Of course, at the moment we can only tell whether they're mature or not, and there are some other tests. Do you think in the future we'll be able to better predict, apart from the age of freezing, what the quality eventually is, to give a better idea of how many eggs she will need to freeze?
That's the dream of any embryologist, to be able to predict the quality of our cells. I think it is difficult because it's a multifactor factor. It's not only metabolism, it's not only chromosomes, although we know that chromosomes has a wave, which is very important. But step by step, we will have additional information to select our embryos, and I think also the oocyte by using new technology, and I think especially biological, molecular biology. But it's difficult to predict. Okay. We didn't do so much in the last 20 years, so I expect that the next 20 years will be better.
Okay. And also the type of stimulation protocols. This is very effective. Yeah. More questions? If not, thank you very much, Laura.
Thank you.
And